I'm Joanne Iennaco, and I'll be talking today about the impact of aggression exposure on nurses and calling for change in terms of how we handle it. This talk has three parts. First, I'll talk a little bit about the evidence on the problem of workplace violence. Then we'll discuss ways to measure workplace violence, and finally consider strategies for violence prevention. We have a challenge in healthcare. Workplace violence exposure is a dual issue. We're concerned with both worker safety and patient care, including interventions and safety. Most of us enter nursing because we want to help people, and it's especially distressing when patients become angry and aggressive. Based on worker injury data, there's a 5 times higher rate of violence in health and social services, 10.4 worker injuries versus 2.1 per 10,000 full-time workers. And the rate is 10 times higher in psychiatric hospitals, with a rate of 124.9 compared to 12.9 in all other hospitals. Worker exposure information is limited. Instead of actual exposure data, we use workplace injury or mortality rates, and common measures used to monitor patient aggression don't capture individual workers' exposures. So underreporting is a major problem. There's many consequences of aggression. Patients may not get their needed care due to disruptions from aggressive behavior, and for other patients, there may be emotional effects, including fear, anxiety, sleep disturbance, or their own care being disturbed. There are many worker health effects from aggression. They include mental health problems, such as stress-related symptoms, worrying about violence or going to work, anxiety, irritability, hypervigilance at work, poor concentration, and sleep disturbance. Mental health disorders also commonly occur after assaults, including post-traumatic stress disorder, anxiety disorders, and depression. Acute reactions may occur with folks who've been assaulted being moderately to extremely bothered by memories, thoughts, images of the attack, or flashbacks. Physical health can be impaired, including musculoskeletal injury, bruises, bites, abrasions, scratches, lacerations, with medical treatment being required in some, and disability and life-threatening injury occurring usually often in only a small number of events. Workplace safety and environmental concerns include increases in patient adverse effects with increased events, and some studies find staff feel afraid of their patients. Work-related outcomes include low morale, poor work performance, increased burnout, increased use of sick leave, decreased worker commitment to the workplace, and that results in turnover and the risk of cycles of low staffing, need for use of temporary staff, the increase in aggressive events, and this all cycling may result in lower standards of care. Measurement is challenging. Most measures result in underreporting of aggression exposure. On the other hand, measuring well can have great rewards for both patients and staff safety. Accurate measurement improves our ability to see the impact of interventions and help us understand what actually works. Accurate worker exposure information helps us understand the consequences of exposure on workers. This slide has a list of common measures that are used for both patient rates and worker exposure rates. The problems with these measures are that they report only the most extreme events at the highest end of the continuum. For example, rate of restraint use does not equal the number of patient aggressive events, and worker injury occurs in only a small proportion of events. So that both of those, when used as proxy for rates, result in underreporting. What we need is a measure of the actual events and exposures. So for the patient rate, we need the number of aggressive incidents per patient days. And for worker exposure rates, we need the number of aggressive incident exposures per worker per hours worked. This slide shows us data on the actual rates of patient aggression and worker exposure based on use of handheld counters in inpatient medical units and inpatient psychiatric units. My research groups completed these studies to try to identify the actual number of events occurring and the worker exposure associated with those. As you can see in the top section, there were between 2 and 3 events each day on a 20-bed medical unit. 2 being verbal and about 1 was physical. As for nurse or worker exposure, the rate was about 1 per 40-hour work week, most often of verbal aggression and less frequently physical aggression. At the bottom, we see the same measures from staff in inpatient psychiatric units. The patient rate was almost 7 events a day on a 20-bed unit, and workers had approximately 6 exposures per 40-hour work week. In the middle, you see rates obtained from both published rates in the literature and from counters. On the left, we see a patient event rate from the Veterans Health Administration data of 16.2 events per 100,000 patient days. In our study, that rate would be 4,264 events per 100,000 patient days. On the right, you can see reports of worker exposure. One study simply asked, were you exposed to workplace violence in the past year? And 75 to 100% of staff said yes, and they estimated they were exposed to approximately 20 events per year. Using counters, we can get a more specific and accurate rate. In our study, this was approximately 60 exposures per worker per year. Depending on the choice of measures, the problems include that rates might be lower or incidents appear less frequent, and we don't learn about what works in our intervention strategies. We end up lacking power to determine differences in characteristics of aggression or of the impact of prevention or intervention or the impact of exposure on workers. This slide shows you a breakout of the data from the aggression exposure study in inpatient psychiatric units. All the measures we used were more accurate than counting restraint events. Using handheld counters, the number of events reported was 34 times the number of restraint events. This shows the degree of underreporting that occurs based on the kind of measure that is used. When this happens, we don't see the full continuum of events, and we have gaps in our understanding of what works to reduce aggression. On the right, you can see a picture of the counter that was used in this study. Now some thoughts on the challenges in measurement that impact prevention and intervention. Counter use offers more information and insight into successfully de-escalated events. For example, in the AIMS study, 75% of events were resolved just by talking to the patient. In use of counters, the staff see the prevented events. It shows them the successes of their intervention and validates the hard work that is done and that is really, for the most part, hidden. It also validates the need for good self-care. In terms of incident and injury reporting, the major problem is people don't fill them out. There are many reasons for that underreporting, including that the systems aren't very user-friendly or aligned with staff workflow, or that staff may fear consequences after reporting, or once they report, they see no change happening. To learn from events, we need unit-based event reporting and debriefing and risk assessment, and we need to engage as a team in these activities. Structured risk assessments show the need for active prevention and intervention. We need to be involved clinically and therapeutically in engaging with our patients, and we need to be able to use de-escalation interventions with people who are anxious, angry, or aggressive to prevent aggressive events. Education and workplace violence prevention training is not often used for all staff in all settings, and yet we know that there are events happening in all settings. Topics in these education programs vary, but the evidence tells us that de-escalation training works. We also need to support nurses and our staff with self-care and resources for victims of assaults. Administratively, we need policy and procedure and written security plans to guide reporting and work that is done to improve care. Many workplace violence prevention models exist. Two of the most that are best known or studied are the 6 core strategies by Huckshorn and the Safe Words model by Bowers, and both use trauma-informed approaches. Both also offer multimodal interventions that include education, training, safety protocols, unit-based collaboration, and engagement in prevention. As far as environmental safety, we need to pay attention to controls that would be important to assessing and addressing risks on units. We need bright lighting, visibility. We need to eliminate areas where staff are isolated and at risk. We need to be able to use personal alarms to get help when we need it. And we should be managing exits, entrances, and considering how we're monitoring our units with the use of cameras. We wrote this article to protect nurses. Our group included leaders in nursing who came together as we realized the increasing problem of workplace violence. We urge 5 steps to address violence against nurses. First, federal legislation, which provides for OSHA standards requiring comprehensive workplace violence prevention plans in workplaces. Second, hospital accreditation. Standards should include quality indicators related to violence, including worker exposure and patient assault. Strengthen data monitoring, particularly to monitor worker exposure. Fourth, improve systems by improving workplace cultures and thus increasing reporting of workplace violence. And finally, educational institutions should be required to provide education to nurses on workplace violence prevention so that they enter the workplace with knowledge and skills. Thank you so much for listening and being part of this event today.